And our final presentation of the morning session is as-needed use of controller inhaler okay in mild asthma, the results of the ASIST study, and it's going to be presented by Dr. Sumino. Asthma care is evolving, and as we heard in the GINA update, we see new medications each year, and we're also seeing research in how to better use the medications that are on the market. Dr. Sumino is here today and will speak with us about as-needed use of controller inhalers in mild asthma. Dr. Sumino is a pulmonologist in St. Louis, Missouri, and is affiliated with the Veterans Affairs St. Louis healthcare system. She has been in practice for more than 20 years, and she is a clinician investigator in pulmonary medicine with a specialized interest in asthma. She's actively involved with the American Lung Association Asthma Clinical Research Network and led a protocol for one of their multi-center trials called methacholine bronchoprovocation, influence of high-potency ICS in asthma study. She also leads several multi-center trials in asthma funded by NIH and the ongoing study ASIST, asthma symptom-based inhaled steroid in African American children, funded by PCORI, which is the patient-engaged pragmatic study in asthmatic children. So welcome, Dr. Sumino.
Good morning, everyone. It's so exciting to be here in front of live audience. It's been a while, right? Outside is a little bit gloomy, but we're in New Orleans. And thank you, Tanya and Ann, for inviting me to talk. And I also wanted to say hi to, I can't see you all, but those on the internet in the live stream. I think it is a product of our pandemic that we can do these lives that will actually give access to people who's not here. You know, I'm originally from Japan, so we just did a presentation in ATS, and you know, we had our colleagues from Japan participated easily. So it's nice to have both ways of doing this, although we had some technical difficulties sometimes, but we can all figure it out, right? So let's see. So I don't have anything to disclose, but I'm a pulmonologist, so I also wanted to send my cheers and appreciation to all my colleagues across the nation and the world who's still fighting very hard to take care of very sick patients in the ICU and in the clinics. I hope the pandemic will be over soon and we can have a lot of these meetings again pretty soon. So I'm going to start with a case so that we can think about these patients in our mind, and going to come back to these cases later. So we have a 10-year-old boy with asthma who had symptoms twice a week, but not daily, and had been prescribed a controller inhaler, but not taken it regularly, currently only taking albuterol here and there. Last asthma attack was about 2 years ago, caused by an upper respiratory tract infection. And the mom is worried about steroid side effects and the cost of the inhalers. I'm sure you all have seen somebody like this in your practice or families. Yes, Tanya just said yes. Case number 2. So 50-year-old female with asthma, again, not daily symptoms, but a few times a week symptoms, and a bad week. Bad weeks approximately 2 to 3 times a month, doesn't wake up in the middle of the night with asthma symptoms, but she did also have an asthma attack about a year ago, which was treated with steroids as an outpatient. Had been prescribed daily ICS, took it for a while, but not using it every day, which we also encountered pretty frequently as well. So I will come back to this case again after my talk. Taking controller inhaler every day has been guideline for first choice for over 30 years, but I guess Gina said over 50 years or maybe longer than 30 years. But we have been recommending this sort of a strategy with control the medication, inhaled corticosteroid, to be taken every day. And then the reliever medication, mostly albuterol in the United States, taken as needed when the patient have symptoms. And then the subsequent dose adjustment of the controller medication or the regimen can be stepped down or up depending on their control by the physician. And this has been the guideline choice for a very, very long time. Now, adherence has been mentioned in this session, the summit already a couple of times, but adherence of daily therapy is approximately 50%. I don't have a pointer here, but you can see the table there that's showing, for instance, the average pediatric asthma adherence in the study. And this is basically going from 1996 at the top and then to 2015. So about 20-year span of the study, you can see that the adherence really has not been improved, and it's about 50%. And part of the reason, there's many reasons for lack of adherence, but one of the reasons for the lack of adherence is the concern for cost and the side effects for the inhaled corticosteroids, especially prominent in the minority population. And then those doses and adherence should be addressed at patient visit. But timely physician follow-up is different. Only 40% of the minority children attend recommended follow-up with PCP. And we've been having decades of work and the guideline is still not delivered. The mic is okay, right? The echo is different, but maybe the volume went down. Okay, let's making sure. Okay, so as needed ICS use is an important alternative to treating mild asthma. So we already mentioned, I think it was one of the slides that Tanya showed in the GINA guideline update, is that the mild asthma consists of majority of patients with asthma. We've been focusing on treatment for severe asthma. And of course, I do that for my practice as well too. But actually majority of patients with asthma have actually mild asthma. And this is also the same data has been shown in one of her slides as well too. But the patients who have mild asthma, they also are associated with significant morbidity and mortality. 37% of them with acute asthma, 16% with near fatal asthma, 15% patients with dying from asthma actually only had less than weekly symptoms in the preceding 3 months of this event. It's also difficult to enforce daily ICS when the symptoms are not severe. And then there's more evidence now for as needed ICS in mild asthma. And as we already discussed, landmark changes in the GINA guideline in 2019 and our US guideline in a EPP guideline update was made in 2020. So when I mention about as needed use of ICS, what do I mean by that? It means basically to use a controller ICS with the reliever, which means that taking the ICS based on the symptoms and albuterols and take the reliever inhaler at the same time. So this figure here is showing the daily use of the puff per day. And it's basically showing how it's actually get done. So like in the very left bar, the patient may had an okay day in which they the 2 puffs of the albuterol and the ICS might have been taken, but then maybe there was a good days in the middle. You have like no use there, where in those days the patient had very good days, and then so there was no use of those inhalers. And then on those high bars, 4 puffs a day, there I have it as example, but maybe had a bad day that you had 4 times a day symptoms, and then you needed to take more medicine on that day. And this is done with a goal to reduce the risk of exacerbation and control symptoms. Now, I prefer to use the as needed term here. I think it's the most frequently used term, but it's been, there's many terms that have been used in the literature and in presentation. So it could be used as, it could be called as needed, it could be called PRN, on demand, rescue, symptom driven and intermittent, but I'll be calling this as needed for the rest of my talk here. So for mild asthma, there are two options essentially for as needed use of ICS. So using the ICS, which could be the beclomethasone, Qvar, or fluticasone, Fovent, or mometasone, any ICS with albuterol when having symptoms. And I will call this as needed symptom trigger use of ICS with reliever air. And this is in the NAEPP 2020 update now. And this is, I showed two inhaler here. So one is albuterol, one is controller. So right now, though, we don't have a product available in the US for the combined, but I just also wanted to mention that there's been two completed study, Mandala and Denali, this year. And then actually, this is a result fresh from the oven. They don't have an official publication yet, but the company actually given a news update in September that it showed actually some positive results on those two studies that the combined product will work. So once actually become in the market, these are all phase 3 trials. So I think it's going to go into FDA approval after they actually shown the positive results. So once we have a combined product, it will probably be a very different scene that we have with this as well. But for the sake of the study that we did, we used two separate ICS and albuterol at the same time. Now, the second option is the using ICS formoterol as needed when having symptoms. This is mostly done and studied with a budesonide formoterol product, Symbicort. And there's several large studies that was done in the past 2-3 years. But in GINA, it is in GINA guideline, like Tanya mentioned earlier, but it's not included in the US guideline 2020 update. It's not necessarily because it doesn't work. It's basically because of the cutoff issue and the topic that was chosen to be included because these several large studies, over 5,000, was actually done just recently in the past 2-3 years. So there are potential benefits for as needed ICS. I have a nice picture here about the patient-centeredness. We're all interested in the patient-centeredness here. The ICS dose follows the disease activity. So the ICS have a, of course, it has an anti-inflammatory effect to treat the hallmark of the asthma, which is the airway inflammation. So when you have more symptoms, you have more disease activity, but then you use more steroids with inhaled corticosteroids, which actually makes more sense. It is patient-centered. You don't have to go to the doctor to adjust the medication, allows the patients to control their medication usage. And our study have shown higher sense of self-management by the patient. I will show you the data in my later slide. And it actually, I already mentioned about this, but does not require frequent visit to the doctor to adjust dose. And us and others have shown overall less steroid dose and side effects with this regimen. So prior to do our study, ASIST, there has been control study. It's mostly a randomized control study, blinded double-blind control study was done in AIR that's shown as that is effective. Studies in children and adults in mild asthma, which compared AIR versus twice daily ICS, showed similar level of asthma control and exacerbation. And also less growth impairment compared at 10 months. This is from the PED studies, about 1 centimeter difference, and less ICS exposure in both of the studies. There was also a study in adults with mild to moderate asthma in which AIR and guideline-based therapy was compared and also showed similar time to treatment failure. So our study is called ASIST, it's a very long title there, asthma symptom-based adjustment of inhaled corticosteroid therapy in African-American children. So why did we do this study? The study was funded by Kaharu. So what was unique about ASIST was a real life study. It was a randomized pragmatic trial in 206 African-American children with mild asthma, and AIR was compared to guideline-based ICS. And it was actually a pretty simple study. but it had minimal inclusion-exclusion criteria to be real life. So many of those prior studies or other studies that we do in asthma, we have long list of inclusion criteria, long list of exclusion criteria. And there's also some data out there showing that only 6% of the asthma patient out there actually meets the landmark studies that is included in those guidelines. So to make it real life, we had very minimal inclusion and exclusion criteria in which patients that air is appropriate. It was also an open label study, meaning that the children and the family knew which treatment arm they were in, which medication they were treating, being assigned to, and also the provider knew that, which that is the real life situation there, right? Instead of being blinded, and all of the prior study that I just mentioned was actually blinded, and it was not really real life. And most importantly, our study was implemented by the primary care providers who actively managing the children in the study. So many of the studies that we do, I'm not saying that's a bad way of doing it. I do randomized control trial myself too, but what I'm trying to say is that many of the things that we do, especially when we try to generate evidence, efficacy evidence that we do in our big hospitals or in some settings that is actually isolated for the routine care and implemented by the researcher. But in our study, ASIST was intentionally designed to so that it is actually implemented by the caring physician in St. Louis. All the study visit happened at the PCP office. And you might wonder why we did an African-American children's. Part of it was basically logistics and a feasibility. It's not necessarily, we thought that it's only going to work in this population. It's actually all the other studies that was done in adults and children in both races and any races actually. So it was not necessarily because there was a scientific rationale for that, but it's more of a feasibility issue. We know that there's low adherence to daily ICS in this population, and we did have a existing connection with the providers group that we actually worked with to make our study happen. This is a scheme of the trial. It is actually a pretty simple trial where you had a run-in period in the beginning in which the education of the albuterol and symptom recognition was given to both participants in both arms, and then they were randomized to either one or the other. The control group was essentially followed the daily ICS following the guideline that was adjusted by the provider, and then the air, and then we actually followed them for 12 months. The purple bar is showing the PCP participation. So they did the initial study visit, and then the PCP visit happened per routine care, and then they implemented the study arms. We did have every 3 months visits with a blinded coordinator just to get an outcome. We did needed to do it this way just to keep the outcome unbiased from the treatment assignments that they were on. So this figure is showing the stakeholder engagement. So not only we planned and designed our study to be more real life, but we also engaged our stakeholders in ASIST to make it more real life and relevant to the participants. So in the first 12 months, we actually spent the entire year trying to plan for the main study ASIST. So in the left squares that is shown in the left portion, we did focus group with the family and the patients. We also did provider interview and then got input on the study design outcome and study materials would that feed into the main study. And then we also had a study advisory board, which we sought advice in all stages throughout the whole process over 5 years. And the providers were engaged, as we talked about, that implemented the study. So we have a nice picture of the advisory board here. We had parents, we had primary care providers, we had a school nurse, we had a advocacy group, personnel, asthma coaches, nurse practitioner of the asthma van that we have in the children's hospital. We had a youth asthma patient, pastor of the church who was also a parent of the asthma child. We had many people who were contributing to as advisory board for our study. We searched and found these dedicated personnel by word of mouth, and we had meeting every 2 months. So this is a cake that we ate that we celebrated the recruitment. Recruitment was pretty tough. So, we celebrated 200 randomization. And these are mainly, those folks who'd never done clinical trials before, by the way. So it was pretty tough, but, with the help of the stakeholders and the support, we celebrated our 200 randomization in one of our meeting. And I still remember the taste of this cake. It was really, really delicious. I just wanted to share, because this was a shared effort that we made through the study. So I just also wanted to comment about the stakeholders, because this is actually one of the key things that has to be in there for a successful pragmatic study. We made many changes from the input. So when we're thinking about what outcome to measure, we confirmed the relevance of the asthma control outcome from the focus group, the study name ASIST, and the study logo. Actually, we like the study logo too with the inhaler, but this was actually designed by the stakeholders. We got referrals of the primary care providers for participation, and many places of the study procedures, like the visit, how often we do it, what kind of process we do, all the study forms, the questionnaires, how to provide asthma education, those we really engaged the stakeholders throughout, and it made many changes. Exclusion criteria also was changed as well too. And of course, we had many input for retention and recruitment feedbacks. I'm showing the little goodies that we have here, and this was all made by the contribution and input from the stakeholders. The favorite that I like is, I don't know if you can see, but we have this little red scarf in the back. You see this one here? So this one was a input from one of the parents that said, well, it's cold, and St. Louis, of course, can get cold. So we need some scarf for the kids to avoid the cold air. But guess what happened was the parents was using it more than the kids maybe. But because what happened is that the parent of the asthma, they also have asthma, right? Everybody's nodding here. So anyway, that's good. Still, family happy, mom happy, dad happy, kids happy, they come back in retention. And, we wanted to do that. So anyway, it worked in a little bit a different way than intended, but, but I just wanted to show that we had fun, and really we got great input from the stakeholders throughout the study. So enough for the background here, right? So what do we see, and what's the result? So this is a little bit busy table. I have to show this just to kind of give you an idea of what the population that we ended up enrolling. 103 patients in both groups with an average age about 10. I just wanted to give you a little bit of background. So about 60% was Medicaid insured. And then also you can see, this is kind of showing the patient with mild asthma still having some events prior, but if you can see in the latter half of the table, about more than 40% of them actually had an asthma exacerbation in the past year, with 30% actually had an ER visit. So even those people who we enrolled mild asthma, they did have a significant portion had events prior, but their asthma control, the ACT score was 22, which was pretty good. And then they all had normal lung function. So the asthma control test score at 12 months is what we looked at as a primary outcome. No difference between group in both groups, it was pretty much identical and no different at 12 months, and actually throughout the whole entire 12 months too. We had also had a pretty good retention rate of 87% for a year study. I think that is a big success as well. What about asthma exacerbation? The exacerbation was not frequent, but it only happened about 20% of the time. But it is still, 20% is a number that we could be even lower, but no different between groups. Even comparing the ER visits, it's actually maybe happened a little bit more in daily ICS, but that was not statistically significant, and it was actually equivalent. The biggest thing that we saw, this was not expected because, we think that it is going to be lower, but we were happy to actually confirm that was actually happening. So this figure is showing the monthly ICS use with air. So the red is the daily ICS group and the blue is the air group. So the daily ICS group used 1961 over almost about 2,000 microgram per month ICS, which we use beclomethasone, and the air group used 526, which is 1/4 of the dose that was used by the daily therapy group. So which means that with the 1/4 of dose, the air group achieved similar asthma outcome. The other secondary outcome was also similar. We looked at quality of life scores, lung function, satisfaction, various other secondary outcomes, but those are all similar between groups. And what also we were excited to see was that there were higher sense of self-management with participants on air. There was a, mention about the lifestyle and the self-management in there as well too. But we shown that 72% of the children and the parents in air group thought that they were managing own asthma versus 44% in daily ICS. So there were a significant sense of self-management in the air group, which is very, self-management in asthma is really important. I think the whole group knows about this, but it was nice to see that the sense of self-management was higher in the people who were on 115. 115. Yes. There were, of course, some pitfalls. This was a pragmatic study, so we could not fully assess if they did what they were supposed to do. So we did ask the parents and the older children whether they did follow the instruction. And the parents said in the daily group, there's 72% followed, and the air group followed about 86%. And so the air group did say that they followed it better. But of course, it's a self-answered questions reported as adherence, which may or may not be accurate. But then we were not able to accurately assess adherence in an objective way. We tried to incorporate a snapshot diary that failed miserably. Nobody wanted to film a daily diary. So that didn't work that well. Thank you for the attempt, but that didn't work. Of course, we didn't try to do it for 12 months. We tried to do like 2 months and here and there, but that didn't work either. And, of course, this is based on symptoms. So it's very hard to capture the symptoms in a really objective way. So we were not able to fully assess, and we really did not use one of those fancy things that goes on, because that's not real life, right? So so we didn't really do that. But at the end of the day, we intentionally was okay with this, because like in real life though, when people with asthma get on the treatment, of course we care about adherence, but at the end of the day, you care about how they did, right? So so the outcome that we saw was what we were looking for and what we expected to see, that we were really pleased about as well. But of course, we don't know exactly how many percentage with they actually did to inhaler at the same time. There could be some issues with coupling it when they were supposed to do. Whether that happened or not, we really don't know. So the summary, AIR strategy provided similar asthma control and events in children with mild asthma compared to standard daily therapy. I also showed that AIR required much less ICS, 25% of the daily therapy, and there were more sense of self-management. So I'm going to come back to this case again. Remember this 10-year-old boy, infrequent symptoms, but he does have symptoms. Only using albuterol now. There was a talk about, albuterol only is maybe not a good thing to do anymore. He did have an asthma exacerbation about 2 years ago. And this one last line I put it in is a key, actually, a word about steroid side effects and costs of inhalers. This comes to this sort of talk about the shared decision making as well, too. If you worried about inhalers side effects and the cost, well, can we force daily ICS to this particular parent in the family as well? This 50-year-old, again, not very severe, she has mild asthma symptoms only a few times a week, but he did have asthma exacerbation about a year ago, and but really not excited in taking daily therapy at this point because just only taking albuterol. So I'm just going to end with this slide, treatment option for mild asthma. The traditional ICS with daily traditional therapy with daily ICS is still there. There are people who would prefer to take the daily ICS, and that's okay. So that's one option. And from our study, ASSIST study results and some other evidence, AIR could be an alternative option for mild asthma. And then I didn't really mention too much because we did not study in our study, but the AsNeeded ICS for formoterol is also could be a potential option. So these options should be discussed with the physician and the patients and the family. Again, the shared decision making was discussed, but I think this is a time to also talk about the options in the data out there and talk about preference in which therapy that they wanted to do. There are numerous future steps, but I listed 3 there as a big steps that needs to happen before we going for, well, actually not before, to go forward. Now this ICS, daily ICS plus SABA as needed has been guidelines recommendation for over 30 years. So this is a very new way of taking the medicine. So we do need education and provide tools for people who wanted to do it to understand how they actually going to do this, because it is a different way of taking the medication as well. We do need to disseminate the evidence, or here we are, we're doing it today. So that's great to have you all online and here as well to so that I can share the evidence here. And then the goal is to implement it at the community provider offices. So I just wanted to thank you, everybody, for the attention. I listed my email there as comments, any thoughts after the talk, during the talk, just to be free to send me. And then there is a handout here that, so this is made by Picori though, and it is, I have some of them here. It's not in the packet, it's in the next to the lunch, I think. But one is for the patient, and then the other one is for the provider though. And I didn't make this, by the way, it's made by Picori. But it also, I have it in as a PDF file. I think AN has it as well too. But these are a tools evidence called evidence update document that can be used for patients and their families. And I have some copy if you want them as well. So welcome your questions. Thank you so much.
Yes, yeah, we have a few questions. One from Elizabeth. How did you measure the amount of ICS received in the study?
Yes. So we provided all the medications. So, and that was kind of challenging actually, but so the decision was made when we designed a study that we wanted to eliminate the effect of access. So, if we were to just do a true pragmatic way where we let the participant use their own medicine, we will have to deal with the access issue, right? Refilling and blah, blah, blah. So we don't want that to happen. So we actually provided all the medication. So we used the beclomethasone, QVAR 40 and 80, and then albuterol. So we bought them, we actually provided them. And then we actually, the dose counter was there. So we provided them, we got it back and we looked at the counter and we counted. It was a pretty tedious work, by the way. But anyway, we looked at those and then counted, and we basically got to the monthly dose. And that's a great question, actually, by the way. And so I would admit that that was not pragmatic in a way, but I think when you do a pragmatic study, it cannot be truly real life, because if it's truly real life, it's too messy to get really great data. So it has to kind of be a balance between how much you're going to let it to life, a real life, or how much you're going to want it to control so that you would have a relevant scientific data at the end of the study.
Our next question from Mary: is there any ongoing support, access, or asthma coaching for these patients after the study?
I guess what maybe the question is coming to, like, how, like, after the study, whether they can continue to be maybe on these arms or not. So so these are, as a part of the study, we actually didn't do anything afterwards, other than the fact that, like, for instance, this evidence update document, we sent it to them, we sent a letter saying that what we saw and all that. So we did that. But the good thing is that these were the children and the families that were taking care of the providers that we have still connection with. So the providers who, if they felt that they can still be on air, they left them on there. So, and then some people, they did get on it because the provider know how to do this.
Couple of questions.
Yes.
Like I said, having myself been on this therapy for over 30 years,
Yes.
I have a great deal of like for the therapy. One thing I think it's important to note is that around the world, this is part of guidelines in
Yes.
Canada,
Yes.
Japan,
Yes.
all around the world. We're
Yes.
the last to this.
Yes.
And
Yes.
and I think the question before was aimed a little at, you not only have to give these patients, first of all, we've done shared decision-making, probably close to about 30, 40 patients. I'm yet to find one when I give them the choice and
Yes.
give them the data,
Yes.
information, chooses to take it every day.
Right.
Okay.
Right.
That being said, I think you also have to train them in the use. And I know for myself, at times you may get, and this is the way the Canadian guidelines read, you may get worsening asthma certain times of the year.
Yes.
When I'm exercising
Yes.
more.
Yes.
Then I go to daily,
Right.
once a day
Right.
therapy.
Right.
And we have to give them the permission
Yes.
to go up and down.
Yes.
So this
Yes.
does take some
Right.
coaching,
Right.
and even over and over again,
Yes.
so that they understand
Yes.
what their responsibility
Yes.
is and how they have to be
Yes.
smart for
Yes.
smart therapy.
Yes. Yes.
And
totally
the other
agree.
last thing, it really increases their perception. They're constantly, we're coaching them on how to recognize their asthma. And
Right.
many of these kids can be poor perceivers.
Yes.
And
Yes.
and
And that's there's been more and more work done in that too. I think the ICS formoterol, trial too, that they did some focus group on that as well. But I think, thank you for pointing out the symptom recognition portion of it, because that's one of the potential problem, right? Because, the ICS goes in with the symptoms. So if you don't feel like, or if you don't if you don't feel like you need to use your albuterol or inhaler, then the control medicine doesn't go in. So we did good amount of coaching during our study, but I think the next step, actually, thank you for pointing out, for us to do is also to develop that education as well, not only about how to do the as-needed therapy, but also it starts from the symptom recognition, how important it is to think about that more in this type of therapy, I think.
Yeah, that is something that I wrote down as an action item for Allergy and Asthma Network and for our ongoing education. And that's because we do know it's upwards of a third of patients that don't perceive their symptoms very well, or we all adapt and normalize, right? And say, oh well, maybe it's just because I'm a little overweight or because I'm out of shape or whatever. We all sort of normalize those breathlessness. I mean, it's one of my big things at this point is why don't we stop that and actually say like breathlessness is not just a normal part of life.
Right.
Yes.
Right. Right.
Yes. Children and exercise. Yeah.
Yes.
That's the comment. Yeah. Exactly. If you can't do what your peers do, then that should be a red flag, right? And as far as playing outside or in gym class. So
Yes.
very important that if we are going to move to this GINA guideline recommendation of as needed, that we do more education
Yes.
awareness on
Symptoms.
symptom
Yep.
recognition.
Totally
for
agree.
sure.
Agreed.
All
There's
right.
another question over there.
Yeah, we've got, I think, 2 questions here in the room, and then we're going to be wrapping up. Here.
Hi, how you doing today?
Hi.
I have 2 questions.
Yes.
As far as the air,
Mhm.
how did you administer the air?
Yes. So the drugs that we use, is that the question? How do we do it?
No, how did you administer the air? Did you use a tank? Did you use a compressor? How did you administer
Oh, okay.
using the actual
Yes.
air?
So the actual regimen that we use is that we use beclomethasone, so QBAR, for either 40 microgram or 80 microgram, essentially use 2 puffs together with albuterol 2 puffs. So basically the instruction was that whenever you need to use albuterol, you use the 2 puff of albuterol followed by the QBAR 2 puffs. So, and then we made the dose different from the little kids to the bigger kids as well. Now that's how we did. Some of the other study did it that way. There's some other studies that done in a different dosing or different formulation, but essentially that was how we did it in ours.
Okay. And then my other question too, I agree that the patients, especially pediatric patients, need to be able to recognize their
Mhm.
symptoms,
Yes.
but also they need to recognize the fact that you don't have to be embarrassed
Yes.
to take your medication in front of other people
Yes.
too. So
Yes.
it needs to be an empowerment of confidence as
Yes.
well,
Yes.
because a lot of times children just want to be normal.
Normal. Yeah.
And
Yes.
taking medication
Yes.
in front of someone else and they're staring at you,
Right.
you're not normal.
Yes. Thank you for that
Really
very
great point
important
around the
comment.
stigma
Yes,
and that,
yes.
self-consciousness that, that oftentimes we hear from pediatric patients.
Very nice presentation.
you.
I've got 2 or 3 comms
Yes,
questions. The
yes.
first is, I like your emphasis, and Dr. Buckstein followed up on that in terms of explaining why we're not aligned with the GINA guidelines yet. There are a variety of reasons for that, but
Mhm.
to me, this would be a big deal changer because, as you can imagine, a lot of patients, especially parents of patients, when they look at the 25% steroid use because of steroid phobia, will I think pretty easily buy into the concept. It'll take, of course, some education to
Right.
get there.
Right.
The second is one of the things that GINA guidelines didn't talk about, and your ASIST you didn't mention, but it's really important to state, is when patients are having exacerbation,
Yes.
they shouldn't be using this more than 2 puffs twice a day. So then you have to use a SABA to fill in the gaps, at least during
Yes.
those first few days, because
Yes.
we've all seen patients where they mistake that and they're using their dual therapy 2 puffs 4 times a day, and then you have some side effects.
Yes.
And then the third is, what about the patients who are essentially exclusively exercise asthmatics, or 90%? They exercise 5 to 6 times a week and they use it SABA beforehand.
Yes.
To me, would be an interesting patient
Right.
population who even seem controlled.
Right.
Where
Right.
so
Yeah.
what comments do you have on that?
Yes. So for the exercise patient, I have two comments to make. So as you see, we didn't specifically study that population, but in the ICS formoterol formula, they have studies out there that actually showing that it actually works in that setting as well. So my guess is it is a good good treatment from them, as well. Now, whether you're going to want to use the ASIST rural or the upcoming ICS SABA, hopefully it is come pretty soon, but it's a question, and I don't know if it's going to have a head-to-head there or not. But anyway, it's nice to have more options. So that's out there actually being effective. What we told our study participant is that if they, and we actually enroll people who are prescribed daily ICS. So we did not, we might have included those people who have exercise-induced asthma, but not purely just albuterol to begin with from the providers. So these are patients who are on, it could not be taken, but on the ICS to begin with. So we had a little bit more people who had more symptoms there as well too. But in terms of the exercise, we did tell them that if you know that you're going to have symptoms before, and if you wanted to pre-treat them, actually do the coupling beforehand as well. So we didn't, basically the symptom base, we actually told them that if you know that you're going to have symptoms, if you're going to treat yourself, actually do the way that you're supposed to do with air beforehand.
Okay, fantastic. Thanks again, Dr. Sumino. Give her a round of applause.